Happy Friday and welcome to the Power Talk seminar series from the UAB Informatics Institute. I'm really glad to see we have a big crowd today, and I'm very happy to introduce today's speaker. For many of you, he probably needs no introduction, but not everybody may know him. So it's James Cimino. Everybody calls him Jim. It's good to be on first name basis with him. He is a distinguished professor of medicine at UAB School of Medicine. He's also the director of the Informatics Institute. He has many other appointments and titles, and is very well known. He's a member of FACME, Fellow of the American College of Medical Informatics, and he's recently received the Morris Cullen Award, which is their highest award amongst many other awards. But I know he's very humble and modest. He doesn't like to draw attention to himself in that way. So without further ado, I'd like to introduce his talk. So he presented this talk at AMIA and in the recent symposium in November, and it's a lot of work to go through and find all the most important papers in informatics over the past year. So, but we're happy that he's able to present it for us. So, so Jim Cimino, Biomedical and Health Informatics Year in Review.
Okay, thank you, Amy. So this talk originally was given at AMIA. It was 90 minutes long, and I ran out of time. I didn't get to a lot of the papers that I wanted to cover. I recently presented this course to Georgetown University, or this lecture to Georgetown University as part of their informatics course. I chopped out a whole bunch. It was only 60 minutes. I still didn't have enough time. I've chopped out more, so let's see if I can hit the mark and not have to rush through at the end. We'll see. It was a lot of work, although I had a lot of help with this. So let me just jump right in, get through some of the preliminary stuff. No relevant relationships. We have a relevant relationship with each other, but not with any commercial interests. And we're supported by a number of grants, R21 and by Center for Clinical Translational Science. Not sure where that should have been in there as well. Okay, learning objectives. So I am not going to teach you everything you need to know about biomedical informatics. I'm also not going to pretend that I've got all the important papers of the year. These are papers that were called to the attention of the AMIA working groups in various domains, and then presented to me. And then I picked the ones from the ones they gave me that I thought would be the easiest to summarize, that looked important, and would refer you to read those papers. So just kind of give you a sense of the breadth of informatics research. If you're interested in joining AMIA and want to look into the working groups, you may see domains that match your interest. And then hopefully you'll be inspired to publish your own significant work, and you'll get included next year if I do this or someone else does this. Okay, so AMIA working groups were asked to nominate papers. I picked the interesting ones. I asked for audiovisual materials from the authors, and this is just a guided tour of the slides in this presentation and the papers behind them. And I have a bibliography at the end, and you can go and read about the papers that you're interested in. And I try to make some sense of it all. I'll talk about the process briefly, probably won't have time. And then the end is all the bibliography and stuff. So just to orient you to the slides you're going to see, they are all kind of mostly the same format. The first slide for each working group will have the title and the journal, a first and senior author of the paper and the institution, some summary points, and then I may have more slides with interesting observations, visual material, summaries of honorable mention papers from the working group, and so on. So each working group presented with me with anywhere from 2 to 6 papers, and I chose at least one from each working group, and sometimes more. Okay, so the first working group to send stuff was the student working group, which doesn't really have a domain of its own. They kind of cover everything. And I was very excited by this paper because I'd seen it in AMIA, but I hadn't actually seen the video that goes along with it. And or seen it in New England Journal of Medicine, sorry. And I hadn't seen the video. So this is a neuroprosthesis for decoding speech in a paralyzed person with anarthria. So this is somebody who for 30 years, due to, I believe, a motor vehicle accident, was unable to speak or use his limbs. He had very, very limited motor function. He communicated with a pen on a tablet, but cognitively fully functioning. You can imagine what a nightmare that would be. Moses and Chang from UCSF and UC Berkeley. And so they had this patient quadriplegic anarthria, and they took a very simple idea. They said, let's show this patient a vocabulary of 50 words and monitor his brain. And we will look and see, we'll take those waveforms, and we won't know what they mean, but we'll put them through machine learning, and the machine learning will figure out the patterns that correspond to each of these 50 words. And they had 48 training sessions over 22 hours. They extracted these EEG signals, 128 channels. Doesn't seem like very much, but think about the first CT scans were only 80 pixels. So, you know, we got a long way to go here. They used 10 convolutional neural networks, and they were looking for word patterns. And then they used natural language processing to help figure out next word prediction. So you'll see how that had improved things. And they were able to decode sentences at about 15.2 words per minute, which is about 10% of ideal speech rate, and probably about 5% of the rate that I'm speaking right now. And the error rate was 25.6%, which is actually considered workable. That is, humans communicating, if there's less than a 30% error, there's usually pretty good communication. So I'm going to show you a little schematic. You can see the patient has an implant in the lower left there, actually inside the brain, and it's connected to a connector on the surface of his skull. And there's a prompt, there's a screen that he looks at, and he looks at the prompt at the top, and it may ask him a question that he tries to answer, or it may give him some speech that or sentence that he tries to reproduce. And then you can see, this is just a schematic from the paper showing how they took the raw EEG signals and turned it into words. Okay, and so here's some target sentences, and then they decoded them, and you can see the words in red are incorrect. And then when they use a language model, in this case, they were able to correct all of them, and they did pretty well with that NLP. So let me play this video for you. There's some sound, and the only sound you'll hear is the patient kind of making vocalizations. Some of them you could almost go, gee, that almost sounded like a word, but then there'll be like a multi-syllable word, and you'll realize, no, it's almost random, that they did not use sound input in this. And I think in this one, what they're doing is they're showing him a sentence which will be hidden from you, and he sees it and he's trying to reproduce it, and then they'll show you the sentence. Oh, and the video didn't work. Let's try it again. So the sentence is behind that gray bar there. You can see the language models updating as it goes. And so it nailed it. Pretty good. Amazing. And it's just a start. Okay. Mental health working group. How machine learning recommendations influence clinician treatment selections. The example of antidepressant selection, translational psychiatry. This is Jacobs Gajos at Harvard University. And so, we have a clinical decision support where we have a computer generated recommendation. We show it to clinicians. We expect them to do the right thing, but sometimes those recommendations are wrong. And the question is, what happens when they're wrong? Do clinicians blindly follow them? Does it affect their decision making? And in this case, they were using machine learning recommendations for clinical treatment selection in depression. And they showed 220 clinicians 5 vignettes with antidepressant recommendations, but the vignettes were randomized such that the results were either correct, incorrect, or there was just some kind of baseline. There was no recommendation at all. That's called baseline. And then the explanations that went along, if there was no, there might be no explanation for the baseline. There was a placebo recommendation, which basically just said, here are the patient's ICD-9 codes, and it said depression and some other things. So it was just supposed to give them an explanation, but it wasn't really helpful. And then there was an explanation based on patient features or guideline rules. And they found that that the correct recommendations, people generally were making the right selection with or without the correct recommendations. But with the incorrect recommendations, it actually did lower their selection accuracy. But it turned out the type of recommendation didn't really matter. And so let me just show you real quick let's see, here we go. So this is a sample of what they saw. This happens to be a correct recommendation, and it's saying here's the patient case, and then here's the recommendation for medications. And then down at the bottom is the explanation where it says it's showing you patient features. and saying, yeah, implying, diabetes, because this patient has diabetes, duloxetine would be the best choice. So that's a sample of what they saw. And then you can see here that when they had the correct recommendation, they pretty much performed the same no matter what kind of information they got. It looks like placebo is a little worse, but statistically not significant difference. And then when they got an incorrect recommendation, it did have an influence on their ability to override that incorrect recommendation and do the right thing. So these are just lots of numbers about. So the difference is relatively small, but statistically significant. Okay. And I'm not going to go over I don't have time to go over all these details. Just to give you a flavor. So you say, hey, you know what? I'm going to go read that paper. So that's why a lot of these diagrams are in here. All right. Nursing Working Informatics Group. They always give me a lot of great stuff. Novel Patient Values tab for the electronic health record, a user-centered design approach from the Journal of Medical Informatics Research. And this is Desai, Nelson, and others at Memorial Sloan Kettering Cancer Center. And so they added a tab to their electronic health record screen to provide access to information about a patient's individual values, goals, and preferences. Now, that's obviously important information, good stuff to know. And a lot of it is in the electronic health record, but it's scattered around in different documents. It's in the nurse's notes, it's the doctor's notes, and social worker notes, and some of it's in structured form, some of it's in text. And so what they wanted to do was provide just sort of a one-stop shop. You go to this tab and it pull all that information together. So they got a working group of clinical and informatics experts. Oddly, they didn't have any patients in the group to help them decide what value information to pull. But, the patients don't know what's in the record. They might have said, I have some other values that you haven't thought about. But in any case, they worked with clinicians and informaticians. They did some interviews with stakeholders, and they developed this tab I'll show you. And the early experience showed they got positive reaction. So values were things for assessment, patient personal values. It comes from the clinical nursing clinical document. Family and surrogate decision makers comes from a number of different fields like next of kin, emergency contact, that kind of thing. Living situation, emotional situation, sexual orientation comes from physician notes, and practices and beliefs and religious affiliation, I think, came from chaplain notes. And then communication preferences, illness and treatment understanding information came from several other sources. And then they also have goal of care discussion notes. So I'll just show you, and of course, end of life care, advanced directives, that sort of thing. So, and they provide links out to the other notes. And this is what the tab looks like. So you click on that tab at the top of the chart, and you'll see the AMIA logo is not part of it. The communication preferences, social information, all of that pulled into one place. And then a little feedback thing where they collected feedback, and they generally got positive feedback. Another nursing paper, Modified Pediatric Early Warning Score Innovation Project, MPUs in Pro, mobile-based application development, another way of monitoring a child's clinical deterioration, pediatric nursing, Kartika Nurani from Universitas Pelita Harapan in Indonesia. So there are a number of pediatric early warning scores. These are assessments that are done to sort of quantify a prediction for clinical deterioration in children. So there's the Pius-Duncan has 10 parameters, Pius-Fitzsimon 9 parameters, and then they created one that only had 8 parameters. And this is what they look like. And the reason they did this was that the fewer parameters you have, the easier it is to do the calculation. So for instance, this one does not include pulse strength, intravenous bolus, temperature. So it doesn't include, although temperature would be easy to get if you've got heart rate and blood pressure, they eliminated those because they were comparing to this Pius-Fitzsimmons, which actually has parents' consideration. That is, they ask the parents, how do you think your kid's doing? Does your kid look like he's getting sicker? And they eliminated that one because it's extra data you have to collect. So the less you have to collect, the better. And what they found was the performance of this predictor was indistinguishable from the other scores. So very nice way to make things easier for the nurses. All right, knowledge discovery and data mining working group, evaluating eligibility criteria of oncology trials using real world data and artificial intelligence. And it was in Nature by Liu and Zhao, Stanford University. Restrictive criteria impede recruitment and result in non-representative population. So when you're recruiting people to a study, the more restrictive you make the recruitment criteria, the harder it is to get patients in your study, and the less likely they will be truly representative of the general population you're trying to help. But on the other hand, the restrictive criteria provide a more consistent, homogeneous group that you can study and look for statistically significant things like outcomes. So they used a tool called Trial Pathfinder to figure out to emulate trials based, in this case, non-small cell lung cancer, and they use these data sets from the Flatiron Health data to basically say, okay, we have a trial, we know that this drug worked. Let's go compared to some other drug. Let's go into Flatiron and find people who were treated with one drug or the other and pretend that they were enrolled in a study. And then we'll look at their enrollment criteria and see if they would have been included in the study and what their outcome was. And then they relaxed the criteria to see if that changed the outcome. And they were mainly looking at trial hazard ratios in this particular study. Okay, and this is just a figure from the study showing the different studies that they were looking at, first-line treatment, second-line treatment studies, and then which kinds of things they used in those various studies. What they found really was that when they relaxed the criteria, that is, they removed some of the restrictions, they were able to they actually found that the hazard ratios did not change over time. So that was, suggests that maybe we don't need to be so restrictive when we're enrolling patients in studies, because then we can get larger data sets and we can apply it to larger populations. Education working group, hands-on training about overfitting, Public Library of Science, Computing Biology. Demsar Zupan from the University of Ljubljana, I think, Slovenia. They have a nice tool for teaching machine learning that's called Orange, and it's publicly available, and you can go and look it up and download it. Basically, the idea is to use data sets and these training tools to help people understand what happens when you overfit your data in the training set. So you can go and look at that and see what happens to your training set. You can figure out why you need large number of data instances if you have lots of data features. You can play around with different methods for selecting patients and randomizing data collection, data selection. And this is an example of the screenshot. And so they have a file of data, and it's actually a graphical representation. They call it a tree of pulling data, a sample of data, and that they then use to train a machine learning model, and then they use it to make predictions. And in this case, you see the results, the performance of the model when they tested it. And blue is the, I'm blanking on what these stand for, but blue belongs in column 1, red belongs in column 2, and green belongs in column 3. And you can see it performed really well, that it classified these cases correctly. However, the problem is that they actually used the training data in the test set, so they overfitted their result. And so, in fact, when they went and did a randomization, and said, yeah, let's just give random answers. Well, because green was so prevalent, the largest, green ended up in the green category, and red ended up, in the red category, and blue in some proportion that sort of looks like the correct data. And so the point was here, you could work with this interactively and play around with it and see what happens if you use different methods for doing your selecting your data for training and testing. And they have a nice video for this that you can go to the paper and click on, and it'll show it, but I didn't try to include it here. All right, ethical and legal social issues. Let's see, case for information fiduciaries, the implementation of a data ethics checklist in Seattle Children's Hospital, Jamia Montague and Danks, Seattle Children's Hospital. A fiduciary is a person who has a power and obligation to act for another under circumstances which require total trust, good faith, and honesty. And that's from law.com. Data professionals also have responsibilities. And so we have to develop and use data products in ethical ways. And there are challenges to this, and the authors provide a checklist that you can look at to see if your application potentially has ethical issues, and you can go out and fill out that survey and it'll help you. Here's some screenshots of the questions that they ask. So they ask about potential privacy issues, bias issues, transparency issues, equity issues, and then overall there's overall issues, and then it gives you a score, and it tells you your score, and if your score is above a certain level, then you need to consider whether you need to go back and apply some more rigorous methods to your design and development. And they provided me with this nice little cartoon. Run this by legal department, but run super fast so the ethics department doesn't see it. Okay, ethical, legal, social, honorable mention, U.S. privacy laws go against public preferences and impede public health and research. A survey study, Journal of Medical Informatics Research, Schmidt and Kuhn, Texas A&M University. They surveyed 504 U.S. adults to find out how comfortable they were with sharing their data in different scenarios. It included who they were sharing it with and what the purpose was. And I'll just show you very quickly what out of 72 different scenarios, the bottom 10 here were business and government for profit-driven and marketing, identifying criminal activity. The people were the least comfortable sharing their data in those scenarios. And then the top 10 were universities and nonprofits when it was for public health, education, and government programs. So the as you'd kind of expect. But the point of this is that people are comfortable sharing their data. And it really depends on what the purpose is. And so there may be ways we can share data that that folks will allow us to do, but others that clearly they're going to want to be informed about the purpose. Biomedical imaging tools, and then UNet, a self-configuring method for deep learning-based biomedical image segmentation, nature methods. NSC, Mayer Hein from German Cancer Research Center in Heidelberg. They used a number of different neural network methods that I'm not going to try to explain. And the system automatically chose configurations based on cross-validation of each of the individual methods. And then they had rule-based parameters for on-the-fly configuration, basically taking a data fingerprint to figure out, based on that fingerprint, which of these configurations would work the best. And then it selects the best approach, and it does all of this without manual intervention, and they've given you a publicly available tool. And here's a bunch of screenshots just to see something pretty, but we don't have time to go into the details. Biomedical imaging, these are also from biomedical imaging. Quantification of abdominal fat from computed tomography using deep learning and its association with electronic health records in an academic biobank, and that's in Jamia, McLean, and Witchy, University of Pennsylvania. And it combines classification and segmentation networks, fully automated. And then another paper, artificial intelligence algorithms improves radiology performance in skeletal age assessment, a prospective multi-center randomized control trial that was in radiology by Eng and Halabi at Stanford University. And they were looking at various parameters for measuring skeletal age, and they had better than 99.5% accuracy in most of the parameters. Oops. And they did a clinical trial to show that using this would improve the assessment and final impressions of radiologists who were looking at these images. And I can include them together because they have kind of a similar approach, which is enhance the images or try to figure out something from the image that will help the radiologist make an assessment. So the left is abdominal fat in yellow, and on the right is two hand images, obviously. And in the one on the left, in A, the artificial intelligence tool performed better than the radiologist alone. And in B, the radiologist performed better than the artificial intelligence alone. When they combined them, the AI and the radiologist, they performed better than either one alone. But I like this because it shows you where the AI fails. I like examples that with machine learning, because when the machine learning's right, you go, well, it's right, I don't know why. But when it's wrong, it usually fails for some really catastrophic reason. Not some subtle thing. Like, for instance, suppose a patient was missing a finger, and you go, oh, you know what? Maybe we need to modify our machine learning algorithm to make sure that we're not fooled by missing fingers or something like that. So I'm not sure what it is about this image that made the AI come up with an incorrect bone age determination, but hopefully the folks that are building this can look at that and say, yeah, obviously it's this particular aspect of the image that's fooling it. We've got to modify our program so it'll work better. So I'm always on the lookout for that with any kind of machine learning assessment. All right, clinical research informatics. REDCap on fire, clinical data interoperability services. It's in Journal of Biomedical Informatics, Cheng Harris at Vanderbilt University. So REDCap is a research electronic data capture tool. It's a widely used free license for clinical trials data capture. And so these clinical trials often require data from electronic health records, as we do here. And so being able to pull those data out and put them into REDCap is a very nice function. And people are often doing that with, they build their pipelines. They may be one-off or they may be reusable. They took an HL7 standard, the Fast Healthcare Interoperability Resource, which is a standard for HL7 application programming interfaces, and they basically developed these APIs for use with REDCap. And then the nice thing about that is that clinical or electronic health record vendors are all supposed to have FHIR interfaces with their system to be able to export data. And REDCap, if you have your API on the REDCap end and you've got a standard, you should be able to transport data very easily. And they do an assessment on 82 different projects at Vanderbilt, almost 20 million data points. And just graphically, this is what it looks like. And you can go read the results and how it worked. But what I really liked was the way they break it down. So the first step, you go into your system and you figure out which fields do you want from the electronic health record. And then you look at, you use this tool, this mapping tool, to figure out how are you going to map the different elements in the medical record to the different elements in the REDCap database. And once you've done that, then you can do this extract. And this is just, this is the EHR data. You create a FHIR message that has the data. And their example was blood pressure, but for some reason they didn't have the same blood pressure across the example. So systolic is 140 there, and then it's 142 in the FHIR message. And then the mapping helper, it maps it in, and it's 142 there and 89. So that map, and then you see it shows up there, it's 135. Hopefully this isn't a data quality issue. It's just they weren't paying attention when they created their example. But you can see very nicely how the data can flow very easily. And this is all automated once you've done your definitions. And so you can, if you want to change something, you just simply link a different field in the record to a different field in the FHIR, in the REDCap instrument. Clinical research honorable mention, knowledge base of clinical trial eligibility criteria, Journal of Biomedical Informatics, Liu and Wang at Columbia University. So clinical trial enrollment criteria get authored by folks who may not always know what's going on in things like electronic health records. So clearly they're aware of reality, but maybe not the reality of the source where they think they're going to get their data. So, clinical researchers are not necessarily experts on electronic health record database design. And so what they've done is they've built a knowledge base that helps you map between the medical record terms and the research criteria in a reproducible way. And the idea is that if you can do that, then you can have reproducible research. And I'll let the authors talk about it.
Clinical trials are the gold standard for generating high-quality medical evidence, and eligibility criteria are the rules that every patient must meet to go into a clinical trial. These are typically stored in free text format online, so the Wang Lab has extensive experience in converting these criteria or rules into structured data. One of the ways we can explore this data is by looking at a single eligibility criterion. So to use one example, hemoglobin A1C is a lab test commonly used to look at patients with diabetes. Leveraging the data we've collected, we can look at the total number of trials that use this criterion, both by inclusion criteria and exclusion criteria, as well as a ranking of how popular it is. We can see a breakdown of how this lab test and its values are dispersed across the clinical trials, and can further see distributions for target disease, trial phase, target disease, and example criteria. Additionally, we can see breakdowns of clinical trial eligibility criteria by a disease. For example, looking at type 2 diabetes, we can see the most common inclusion criteria with frequency, as well as exclusion criteria.
Okay.
Jim, just doing a quick check on time. We're just over the halfway mark.
I know. Yeah, I'm watching it.
Clinical trials are the gold standard.
Come on, keep going. There we go. Okay. Well, I'm going to have to speak a little faster. I'm going to have to leave a few things out here. So dental informatics, leveraging electronic dental record data for clinical research in the national dental PBRN practices. And really just, the idea of this paper was that they recruited 99 practices that were in the National Dental Practice-Based Research Network using 2 different commercial systems. They got the vendors to do data extraction for their research study, and they were able to get nearly 100% complete records. That's really phenomenal when you compare the kinds of data sets we get from the general medical records. They're much lower than 100% complete. So that was pretty nice, but I won't go into the details there. Evaluation, people and organizations. There's a problem, now it's the solution. Suggestions for technologies to support menopausal transition from individuals experiencing menopause and healthcare practitioners. And this is Bekonia and Woods at University of Washington, Tacoma. And basically they did brainstorming to get some novel ideas for figuring out how to help patients who are experiencing the symptoms of menopause. And the proposed solutions were, I'll show you on the next page, were largely sort of multimodal, and the clinicians really liked the kinds of input they got from the patients, and they said, you know, it's nice to see what the priorities are and know what they need. And then so they did things like these drawings. So there, the patient is wearing some kind of device on her wrist, and it's sending a message to the practitioners wearing something on her belt. And then the recommendation, you know, some recommendation about, you know, sit down and drink water, ice water, or whatever it is that they're going to recommend. I just really like the way they have listed all these things. And, you know, it's like a multimedia thing with pipe cleaners and, you know, stick-ons and I don't know what those little glass beads are and so on. So there's a whole bunch. You can go look at them. My favorite, though, is this little fan that you plug into your iPhone. And it turns the fan on when you develop symptoms. So I thought that was pretty cool. Okay, evaluation, honorable mention, disappearing expertise in clinical automation, barcode medication administration and nurse autonomy in Journal of the American Medical Informatics Association, Hong, Novak, and others at Brigham and Women's. And you know they're looking at issues around how nurses do their jobs. They are not just doers, but they're also knowledge workers. They apply knowledge to situations and they act in a dynamic way based on situation. And they were looking at how technology can actually reduce the nurse's ability to do that, reduce their autonomy. And they took the example of barcode medication administration, and they interviewed patients or interviewed nurses to find out how do they use the barcodes and how do they sometimes have to work around the barcodes. And of course, when people work around systems, that sometimes can be good for the patient, but sometimes can result in safety issues. And what they found, the nurses, you know, talk about how they're prepared. So they think about, you know, what's going on with the patient, not just the medication administration, but how will other things going on with the patient influence the medication administration. They need to be organized. So they need to be more, it's more than just, all right, open a drawer, take out the medicines, give the patient what they need. They need to be thinking again about all the things that have to be done for the patient and how medication administration fits into that. But they, nevertheless, despite their autonomy being blunted, they own the task. They're responsible for it, and they don't relinquish that. Different roles with different goals. Designing to support shared situational awareness between patients and clinicians in the hospital, and Jamia, Pollock, Pratt, and others at University of Washington. So situational awareness framework is that there's a framework, one framework they looked at is an awareness of signal, of what's going on, a comprehension of signal, understanding what's happening, and then projecting what's going to happen, the result of that signal. So you're sort of looking at the world around you and going, oh, there's these things happening, and this means that, and if that happens, some other thing's going to happen, and some of those are bad, and we want to prevent them. So they used mixed methods of semi-structured interviews, card sorting, and they interviewed, patients and caregivers at 2 sites. That's my diagram of situational awareness, they found that good reasons for supporting situational awareness were patient autonomy, improving outcomes, managing expectations, creating common goals. And the barriers were related to poor communication, cognitive challenges, and unrealistic expectations about what can happen. And facilitators were patient expertise, actually, and observations, repetition, empathy, and comfort, ways of addressing problems that arise in situational awareness. And they came up, I had a diagram, but I've left it out. Okay, Open MRS, Open Medical Record System, Global Good, Impact, Opportunities, Challenges, Lessons Learned from 15 Years of Implementation, International Journal of Medical Informatics, Vermeer, Cullen, and others at Johns Hopkins. And Open MRS is an open source electronic medical record released in 2004, now used in 62 countries, especially low resource, middle income countries. And they surveyed 16 organizations, 16 countries to see how it was being used. And they found that it streamlined operations, improved quality, improved reporting, data quality, availability, and interoperability. So it does a lot of things that you need to do when you have poor resources, you have a distributed healthcare system, with no central organization. It doesn't do billing, so it's unencumbered by those kinds of tasks. And the challenges they had were technical staff to run it, acceptability of the user interface by clinicians, and just difficulty to get training for people who are using it. And technical challenge were infrastructure. So sometimes they didn't have internet or they didn't have electricity, functionality of the system, shortage of documentation, and being able to contribute different groups, the user groups contribute code, but there's some quality control issues there. And this is just a diagram to show you where OpenMRS is used throughout the world, pretty widely distributed. Okay, primary care, digital, let's see how we're doing on time. Digital health needs for implementing high quality primary care. I'm going to skip this one, National Academy of Medicine. Yes, we need primary care, and they looked at digital health as a key part of improving primary care, but I'm going to skip that. Visual analytics, marrying medical domain knowledge with deep learning on electronic health records, deep visual analytics approach, and they developed a tool called DGViz that allows them to do some very interesting things with taking population data and making predictions about what a particular patient's outcome is going to be, and then letting you change information about the patient to kind of see, well, what's going to happen to this patient. And I want to show a little video of this. So this is their screen. This is just a two-dimensional representation of patient populations. Red are patients with congestive heart failure. Blue are patients without, and I don't know what the X and Y axis are in this thing here. And this is showing you some demographics of the patient population, and this hairball will get explained a little later. But I want you to see how they kind of do these what-if scenarios using the machine learning data on this data set. Let's see if we can get this working. There's no audio here. So demographics chart showing just the demographic distribution of all patients. This is the projection view of positions of patients in a two-dimensional space and relative similarities. Red dots represent patients with heart failure, while blue are those control patients. And the knowledge graph shows a whole network structure, and we'll look at that in more detail after the video's over. The patient history view shows various events, and that black line is showing you the likelihood that the patient will develop heart failure over time. Positive means more risk of heart failure in the future. So you can drill down on each of those visits, those little squares, and see what kinds of information is in there, ICD-10 codes and so on. And then it shows you a contribution in the network of things that will influence congestive heart failure in positive and negative ways. Okay. We're going to get on to the two kinds of what-if operations. So they're picking a point in time, and they're looking at the diagnosis, and they're saying, what if we added a drug to the patients? We can remove medical codes. We could remove something that's contributing to heart failure, and say, if we got rid of this problem, maybe the patient wouldn't develop heart failure. Can also add medications and say, if we added a medication, would the patient be more or less likely to go on to heart failure? And you can see the dotted line there is the projection of okay, that's the end of my video. But you can go, well, that was unhelpful. You can go off and all right, so I've stopped screen sharing because I screwed this up. So let me swap presentations. Let me find this again and try to share it. Oh, and I didn't share it. I bet I didn't share it with the video audio. So let's stop again. Let's try sharing the screen with sound. There we go. Are you seeing the screen again?
Yep.
Good.
Yep.
Sorry about that. I somehow killed PowerPoint. Let's see if I can avoid doing that again. There we go. All right, this is that hairball, and I've just got some screenshot. I'm just going to kind of zoom in on it, and you can see there's some concepts in there, and it's actually a nice semantic network. You can drill in even further to see how these things relate to each other. Okay, visual analytics, honorable mention, mapping scientific landscapes in UMLS, a scientometric review of JAMIA Kim and Zhu, Children's Hospital of Philadelphia. Basically, they were looking at citations about the unified medical language system, and they created some very nice, heat maps of different topics, and then different articles and how they influence, how they're influencing each other through co-citation. They picked out one particular on Rossi and Mahino. I'm not sure what. It's not a particularly significant one. They've just drilled in on it, but I really like this one because if you look in the upper left corner there, you can see they've referenced a couple of my papers. Okay, global health. Multivariate statistical evaluation of actual use of electronic health record systems implementation in Kenya in Public Library Science 1. And this is from University of Bergen. And then you looked at Kenya EMR and an open source EMR. And they found 14% of the sites were able to exchange data. 97% of them had standardized terms, and 50% of the patients had national patient identifiers. And then a similar effort in Botswana in biomedical decision making in biomedical informatics, BMC, sorry, biomedical informatics decision making. And this one out of South Africa, but it was looking at 18 facilities in Botswana, and they all had electronic health records. There's lots of interoperability, but interestingly, the public systems exchanged information with each other, and the private institutions exchanged information with each other, but there was not much information exchange across the two types. And that's just to kind of show you, to do some side-by-side comparisons. Botswana apparently, is a wealthier country by comparison. Consumer and pervasive health safety concerns with consumer-facing mobile health applications and their consequences is a scoping review. They looked at studies to understand what are the concerns related to patient-facing mobile health applications. So content quality, obviously, are all, there's lots of different aspects that are concerned. And then software functionality. So if it's actually executing any kind of logic, there's also concerns around that. And they've enumerated all these. And sorry, I'll let you go see the paper for the details. Consumer pervasive health informatics opportunities involve patients in hospital safety, a conceptual model. So they surveyed patients and caregivers about undesirable events that occurred, and the intent was to figure out where would you develop informatics solutions to these events. And they came up with this framework. So stage 1 is the occurrence of the event, and then stage 2 is the possibility where you can intervene in the event, and then stage 3 there's emergence of harm. So you want to intervene before there's harm, but then if the harms do emerge, then what can you do in reaction to them? What I thought was interesting is that nobody said, hey, how about introducing things that occur before the undesirable event? Preventing the undesirable event. For some reason, that wasn't included in the framework. Also, consumer and pervasive health, personal health information management among all elderly adults. And they were just looking at how elderly adults manage information activities like seeking, tracking, organizing, and sharing. And they looked at the methods they use. So a lot of paper-based tracking tools. Organizations varied from a nice filing cabinet to a messy desk, and emergency planning seemed to focus around the refrigerator. So lots of things put up on the refrigerator for emergency planning, emergency medications stored in the refrigerator. Clinical decision support, recommendations for safe and effective use of adaptive CDS in the US, position paper, and I need to start skipping more of these papers, I'm afraid. So they were looking just at a framework for just looking at adaptive clinical decision support, and this was just looking at what standards are used in decision support in different settings, and the title kind of says it all. And you can see FHIR, that bond thing is used quite a bit. SMART, which is a data standard for exchanging health record information with hand-based mobile applications, also a big thing. All right, but I need to get through these because we haven't talked about something very important. But let's see. I'm going to skip this one. But I did like this. I have to skip this diagram. This is a very cool diagram because it allows you, the blue is sort of the true positives, and then the faint blue are the false positives and false negatives. And when you summarize the blue in any column, you can see the recall and sensitivity. It doesn't reproduce well on the screen, unfortunately, but I really like this diagram. Okay. Improving reporting standards of polygenic risk scores. We're going to have to skip that one. Natural language processing. We're going to skip that one as well. So the summary. And actually, of course, I don't have a summary yet because I haven't talked at all about COVID-19. So there were, I picked out all the different papers from the different working groups that are on the pandemic. We'll spend just a few minutes on that. There was one suggested that actually I presented last year at this talk, the National COVID Cohort Collaborative, the MC3. They requested OMOP data from multiple sites. University of Alabama was one of the first 4 to provide data, but lots of academic medical centers responded quickly. They created an enclave, and this is their 2020 paper. And this were the statistics from the 2020 paper. But I included it in this year just because I wanted to show those are all the sites that contributed data. This is an updated image. And this is today. Now they've got 10.4 billion rows, 950 million clinical observations, 9.3 million persons. So these are people who have been tested for COVID, and of those, over 3 million were positive cases. Of course, this is a small number of the total number of people in the country, but it's a pretty representative data set. Linked electronic health records. This was England, did the same thing. So we'll just skip over that one. This was using OpenMRS for rapid deployment of now. Oh no, so this is the dental one. They created some very nice screening tools to help triage patients who had dental pain to whether they should go to the clinic or whether they should go home and wait to make sure they don't have COVID-19, or whether they should go to the emergency room where they could actually take care of somebody who might be COVID positive. And they actually, they were able to effectively reduce the workload on the clinic and reduce the exposure of the dentists in the clinic to patients who were at high risk for active COVID-19. Okay, OpenMRS. So these were folks at Regan Street where OpenMRS was developed. They actually used it to deploy an emergency EMR in the disaster field clinic, and they did it within 2 weeks. It was pretty cool. One of the things, they had a problem with handheld devices working with the system, and there was a group in Uganda who was working on OpenMRS, and they had actually solved the problem already. So they shared their fix with Regan Street, and so that was pretty cool. And it's just their deployment schema. Tracking COVID-19 burden in India. So here's the India version of their data sets. We won't go into it, but you can see there's lots of different places where informatics has contributed to addressing the pandemic challenges. This was just sort of an opinion piece from 15 academic medical centers about how electronic health record data contribute, and they talk about challenges and so on. And I like this table because they really go into the idea of if you have a disease-based registry versus a clinical network, and what are the benefits and challenges of each of those. And then they looked at individual efforts to share data. So there's 4CE that I think I mentioned. There's N3C, which was the National Collaborative, so on. So there's you can find your favorite EHR data sharing activity in their little chart. All right, Dutch Warehouse, another version, and they were very successful working with multiple different kinds of electronic health records to pull data together. And then accurate protein structure prediction with AlphaFold. So this is in Nature, Knowledge Discovery and Data Mining, Jumper Hassabis, and a company called DeepMind in London, and Seoul University. And AlphaFold is their machine learning tool for predicting protein folding. And and it performed extremely well in this challenge, the critical assessment of protein structure prediction. It's an annual challenge. This is CAP14, and CAP14, of course, included proteins from the SARS-CoV-2 virus. So I'm going to let you see their little video.
The Prime Minister has announced the most drastic limits to our lives that the UK has ever seen in living memory.
I must give the British people a very simple instruction. You must stay at home.
We were prepared for CASP to start on April 15th because that's when it was originally scheduled to start, and it's been delayed by a month due to coronavirus. I really miss everyone.
CASP started on Monday.
Can I just check this diagram you've got here, John? This one where we ask ground truth. Is this one we've done badly on?
We're actually quite good on this region. If you imagine that we hadn't have said it came around this way, but had put it in the
down
right
instead.
spot.
Yeah.
One of the hardest
proteins we've gotten in Cas thus far is a SARS-CoV-2 protein called ORF8.
ORF8 is a coronavirus protein. We tried really hard to improve our prediction, like really, really hard. Probably the most time that we have ever spent on a single target.
So we're about 2/3 of the way through Cas, and we've gotten 3 answers back.
We now have a ground truth for ORF8, which is one of the coronavirus proteins. And it turns out we did really well in predicting that.
Amazing job, everyone, the whole team. It's been an incredible effort.
Here what we saw in Cas14 was a group delivering atomic accuracy off the bat, essentially solving what in our world is 2 problems. How do you look to find the right solution, and then how do you recognize you've got the right solution when you're there?
All right, are we mostly here? I'm going to read an email. I got this from John Malt. I'll just read it. It says, John, as I expect you know, your group has performed amazingly well in Cas 14, both relative to other groups and in absolute model accuracy. Congratulations on this work. It is really outstanding.
Okay. So it turns out that the CASP organizers said that DeepMind had basically solved the protein structure prediction problem. Of course, it looks like a lot of manpower involved in that. Lots of lessons. One of the lessons is to make sure you have a really good videographer on your budget, on your NIH grant budget, so you can videotape these things as they're happening and produce videos later. Okay, so summary of the pandemic in 2020. When I did this, it was, we were in the beginning of the pandemic. Not much had been published, and so there some of the domains. There were patient care. There were 2 this time. Then public health, population research. There were 4 this time, and then there are 2 on literature analysis. A lot of the working groups had not produced papers relevant to COVID-19, but this time 10 of the 20 did. Visualization was used in a lot of the papers from last year, but they weren't from the visualization working group, but this time they were. And so actually not imaging so much, but analytics. And so the questions that arose are, how should the electronic health record evolve to contribute to learning health system for the next pandemic? And there was a couple on functions, but nothing on improving the content of electronic health records. But bottom line is, investment in electronic health records and data sharing paid off big time in ways that we did not directly predict when we were doing it. Okay, I don't have time to talk about diversity, disparity, diversity, and equity. And hopefully I have a summary slide here of those papers. I pulled them out separately from the different working groups. But what I found was that people are looking at how machine learning algorithms can introduce disparities, especially racial disparities. There were papers looking at workforce diversity and looking at equitable resource allocation and equitable access. What I thought was missing was informatics studies to address patient care disparities, EHR data collection to help us address racism as a determinant of patient health, and EHR data collection to address racism as a public health crisis. So I didn't find those. That doesn't mean there aren't papers on that, but nobody submitted any. And also no papers on anti-racist electronic health record functionality and clinical decision support. And don't really have time to talk about what I mean by that, maybe in another one. Phenotyping, playing 20 questions, going to the records to try to figure out what is going on with patients. We don't have time to cover that. I will just point out that the phenotyping used in the COVID-19 studies, they were, each site used a different set of criteria for figuring out who actually qualified as being someone with COVID-19. Okay, so I will just get to my summary. I don't have to talk about fixing electronic health record. So really sorry to tease you with all that stuff. But the different working groups, contributed to papers on pandemic, on disparities and diversity, phenotyping, fixing the electronic health record. And this will be in the video, and we'll share the slides for anybody that wants them, so you can see these at your leisure. There were 4 scoping reviews, 4 systematic reviews. There was only 1 and 3 in 2020. And if you look in PubMed, you'll see there's a big jump in the last 2 years in scoping reviews and systematic reviews, which I suspect is because people can't get to their labs and clinics to do research. So they're just doing literature searches and doing the research that way. And lots of overlap between different domains, which again, I'll share the slides and you can look at these individually, but lots of overlap. Okay, so the 20 working groups, 81 papers. I presented 60 of them. You can see biggest journal, the American Medical Informatics Association, JBI, Nature, Journal of Medical Informatics and Research. So Nature is the one, journal that was heavily represented, that not an informatics journal, and lots of other journals contributed. And there's all the papers. And now I'll just let the credits roll. Where's my credits? There we go. And and I'll take any questions if I have time. I've got like 3 minutes for time. And I see the chat. I need to run, and fantastic, and wow, it's amazing, and feel free to enter comments. Okay, so people can put comments in the chat, or I will, I don't know what happened to my, there we go. Or just blurt out your questions. I'm not sure I can answer questions about specific papers, but I can try. These are all people that contributed, authors that submitted. Every author I contacted except one provided some kind of information. I didn't use it all. There's the bibliography. It goes on forever. No questions? I'm gonna skip down to this. And I actually had a dedication at the end.
There's a question about slides being shared.
Oh, can you share the slides? Yes, I'm not sure how to distribute the slides, but if you email me, seminarj@uab.edu, I can send them to you, or maybe I'll put them up in a box or someplace and provide a link. It's a big file. It's about 120 megabytes. Okay. And the last slide actually has the whole bibliography. It's coming up here. Okay, well, thank you for your attention. The video will be recorded, and I guess we can send it out to the list. And I will also send out to the list a link. I'll put the slide somewhere in box and make a link for folks. And if you're not on the list, get on the list. And meanwhile, you can email me directly, and I'll send you a link. So thanks for your attention, and have a nice weekend, and happy holidays.
Thanks, everyone. Reminder, no seminar next week because of, as Jim mentioned, Thanksgiving. So happy Thanksgiving, everybody, and we'll see you the week after that. Bye now.
Thanks, Jim.